So live from Dynatronic Studio at 7030 Park Center Drive, we bring you Dr. Stephen Guffey.
Thank you. I'm introduced to the concept of deep tissue oscillation. One of my partners in my practice actually is a tennis player, fairly good tennis player, an instructor, and he has chronic or had chronic extensor epicondylitis or tennis elbow. And in fact, it was so bad, he'd had it for so long, that he lacked about 7 or 8 degrees fully extending his elbow. He had a lot of scar tissue in the elbow. He continued to play tennis, but was in a lot of pain. We became aware of this type of treatment, treated him, and used him as a test case. And of course, he's been in the business a long time and very cynical, and so we felt like that would probably be a fair test. We treated him once with the treatment, and I spoke with him the next day, and he actually reported that within 20 or 30 minutes after the treatment, he had become pain-free. And we measured his elbow range of motion the next day. It was completely full. And to my knowledge, he's continued to play tennis without any discomfort since we treated him once or twice with the deep tissue oscillation type treatment. So I was quite impressed, and therefore then became involved, with the treatment. And have worked, of course, with Dynatronics to develop the product that you all, I don't know how many people have seen it yet, but I've been using this product that you see here for about 2 or 3 months now, I guess, 2 months in my clinic. We use it daily. It's a very good product. So I'm excited to talk to you about it. The thing that is most impressive to me about this particular technology is that I have an orthopedic outpatient practice, and I would say probably 85 to 90% of the patients that come through the door in my office are people that we will use the device on. So it's very useful in that sort of a setting. Now, I have some friends who I've introduced to the product that treat wound cases. And they're actually using the device to facilitate an accelerated healing rate on some recalcitrant wounds. This is not something I have any experience at, and probably will not speak a great deal about today, but I did want to bring that point up because it's not just an orthopedic type treatment. It's very effective for any sort of tissue repair type situation, which is kind of neat because it does go hand in hand with the light therapy. We use, most of the time when we're applying the deep tissue type of treatment, we're also using it in complement with the light therapy. So it's a very nice marriage that Dynatronics has put together for you here. My job initially, what we're going to do is I'm going to try to explain the physiology of this particular treatment briefly without being too overly technical. It's actually quite simple. And then I'm going to spend a lot of time demonstrating. I have a person who's going to act as our patient here today. We're going to demonstrate how to do the treatment and then talk about it. And hopefully the folks that are in the audience here can ask some questions that will help us, lead us into some good discussion. And those of you who are watching us remotely can do the same. And Scott's going to relay those questions. So that's going to be the order of what we're going to do. Sound good? Okay. A little bit of feedback is always helpful, right? So that I know what's going on. Okay. Now, those of you that have the device, is this document, Larry, available yet? The manual that we put together?
Yes, they're in the hands of all the reps.
Okay, so everyone has seen this, and most of the stuff that I'm going to discuss will be found in that document. The best way to start to understand this type of treatment is to start with the understanding that there's not anything that is particularly new or different in terms of the general practice that physical therapists or chiropractors, athletic trainers would incorporate to use the product. It's simply using things we already do in concert in a unique kind of way. So you're not really having to learn something that's totally brand new. You're taking things you already know and then putting them together and using them in a specific way. We are talking about electrotherapy and massage, basically, is what we're talking about here. Now, I use some more specific manual techniques, which we'll talk about, in the treatment from time to time. But at the end of the day, you go a long way if you'll look at this as a combination of electrotherapy and massage. Two modalities or treatment techniques that we use all of the time. And this is discussed in the manual that you have. briefly, let's talk about what goes on here. Whenever we do deep tissue oscillation, we're basically setting up two electrical fields. One that's established in the operator and one that's established in the patient. And they're brought very close together, but are separated by a non-conductive medium or layer, which is in the probe or in some of the hand techniques that I've been allowed, to talk about briefly here today. So there's not ionic conduction like we typically do with electrotherapy. That is, ions flowing from the device to the patient. That's not taking place, but the two electrical fields are very close together, and as they come close together, then matter in the operator and matter in the patient is either drawn toward the field or repelled from the field. And this is how we get the vibration or oscillation that's taking place. In the past, you've used electrotherapy. We cause the muscle to contract, smooth or skeletal muscle to contract, and we can get a vibration. But in this case, what we're doing is actually pulling the charges on matter toward or repelling the charges from one another. And that gives us an oscillation in the tissue. A deep oscillation, a resonant type of oscillation. It's extremely comfortable, comfortable both to the patient and to the operator. Causes the same sorts of effects that we get with electrotherapy. And then by adding the manual nature to the treatment, we get a mechanical type of physiologic effect in the patient. So let's talk about that. First, the electrotherapy aspect of the device gives us a really good opportunity to deal with pain. And you all are familiar with using electrotherapy to treat pain. When the situation is acute, we tend to use higher frequencies with electrotherapy. We use higher frequencies with the deep tissue oscillation. Higher can be classified as anything, 80 to 200 hertz. If the problem is more subacute, many of the cases that we treat in the clinic are probably staged as subacute, then we'll use more of a mid-range type of frequency. And if the problem is more chronic, we might use then a lower frequency. The lower ends up to maybe 25 hertz, something like that. Many of the treatments that we deliver in the clinic, unless they're very acutely postoperative, are done in the range of about 80 to 120 pulses per second, somewhere in that range. Okay, and then the second factor that is brought into play here is the manual aspect of the treatment. We can literally move tissue, move fluid by manually using the probe device or hand, however we want to do the treatment, so that we get a physical movement of tissue. Now, many times with the patients that we see that have long-standing orthopedic situations, they will have adhesions, they'll have areas of soft tissue that have shortened or tightened, and so by manually applying the treatment, we're able to loosen the tissue. Sometimes we do it in the direction of the tissue fiber, sometimes cross-frictionally, which again I will demonstrate later. But this mechanical or manual aspect of the treatment is very effective. And it is not smart to overlook this fact. This modality has the operator, the therapist, the physician, whomever's doing the treatment, laying hands on the patient. And while it is true that requires you be physically present and some time involved, it's also extremely therapeutic to lay hands on patients. And I like the modality in great part simply because there's laying on of hands. Patients love that. And it is important to establish a therapeutic relationship with the patient. The absence of that slows down the healing process. Psychology is important, and we shouldn't make light of that. So the modality is very good in that respect. Okay, you can see on your screens, hopefully in a little window right to the top left, an overview of frequency ranges that you should be familiar with if you've dealt with electrotherapy in the past. There's nothing really new or different about the treatment in terms of the electrotherapy. You adjust just like you would if you were doing E-stim of another common example. The circulatory benefits, probably it's important to discuss those just a little bit more to make them clear. Because you will notice if you treat patients yourself with this device and you do a series of 3 or 4 patients in a row, you may in fact feel a little bit lightheaded because there's a powerful circulatory benefit that is associated with this situation. I found this out sort of inadvertently by treating 4 or 5 people and then standing up real quickly one day and sort of felt lightheaded. We get, with the treatment, a significant relaxation of both blood vessel and lymph vessels because of the smooth muscle inside the vessel wall. It's actually relaxed when the treatment is done. And so when you couple this with the mechanical nature of the treatment done from distal to proximal, like we're going to demonstrate in a moment, you get quite a lot of movement of fluid that is perhaps stagnant, that's been trapped somewhat around the area of injury due to muscle spasming and the capillary bed having pressure on it. This really moves that fluid very nicely. When the situation is acute, what we tend to do is use a high frequency, a fairly light touch, and then, as I said, massage the area basically from distal to proximal. We see a pretty significant reduction in edema initially with postoperative patients. Total knees are a good example, and we'll work on that in a moment to show you exactly what we mean. But this is a really strong benefit of the treatment that you don't get quite as much of a response with the traditional electrotherapy by combining the electrotherapy and the manual aspect of it. You get a much bigger response. Patient's pain, therefore, is diminished because a lot of times the pain the patient experiences in an orthopedic situation initially is as much from the edema that's associated with a postoperative case or a real acute injury as anything else. So removing that edema, getting it to respond based on this circulatory benefit is very helpful clinically. Sometimes we see chronic edema in patients that have had total joint replacements or that have had chronic injuries that perhaps are not postoperative. They just have a mild to moderate amount of edema that stays there all the time. We found that we get a pretty good result in moving that as well. The thing that seems to help the most there is to clear the tissues above the site of the injury and then treat the site of the injury secondly, after we use the treatment to clear above or closer to the heart. So we can treat the chronic edema as well. I often will use this treatment in concert with doing joint mobilization. And the reason that I decided to do that is because the patient gets, as we mentioned a moment ago, a lot of pain reduction from the treatment. And then therefore then have less increased muscle tone around the joint or segment that you might be treating at the moment where the injury has occurred. And this allows us to do manual therapy more effectively. Joint play type movements, range of motion type things. So we have an electrotherapy effect, we have pain control, we have a mechanical effect, movement or circulatory effect, movement of fluid, and then this allows us to more effectively deliver joint mobilizations, stretching, range of motion type treatments, and we get a lot better outcome as a result of it. You can see an indication, hopefully now on your screen, a list of indications. They're pretty much standard, the type of things that we would use electrotherapy or manual therapy or massage for, so there shouldn't be anything there that's particularly new or different. I think in my clinical experience, if there is joint or soft tissue involvement, and of course if you're in an orthopedic clinic like I am, that's almost every patient that walks through the door, this is a treatment that is appropriate. And in fact, for a lot of the patients that we see, it's the first thing that's done to the patient when they enter the clinic. We use the deep oscillation, they become a little bit more comfortable, their movement is freer, they can then engage in their exercise program more effectively with less pain, greater range of motion, to get more benefit from the treatment, and then post-exercise we may do the typical ice or that kind of thing. Very good at increasing the benefit of the exercise program. Patients are much more engaged in their exercise program after we deliver this sort of treatment. So here's your list then, and some discussions that you can see, giving you some details on times, treatment times, and so on. Rather than bore you going through those now, we'll do that whenever we're treating a patient. We'll talk our way through what we would do there, and it'll probably make more sense to you. I do want to talk just a little bit about contraindications. So let's move real quickly to those. I'll handle the applications better whenever we do our demonstration. Please take a look on your screen at the contraindications. It's always good to know what you shouldn't do. You should view this treatment as an electrotherapy treatment first and foremost. Okay? So if we have a situation where electrotherapy would be contraindicated, then this treatment would be contraindicated as well. Another thing that you should keep in mind, there is a strong circulatory, as I've already mentioned, there's a strong circulatory effect from this treatment. Therefore, if you have an infectious situation, the spread of that infectious situation is enhanced, and probably you shouldn't be treating the patient in that case. A malignancy in the area of treatment is not a good idea because, again, there's a strong circulatory benefit that ensues here, so you want to be careful about that. The issue of pregnancy is a standard contraindication. To my knowledge, there's no research that particularly says that there's going to be any negative outcomes. I have no idea, so we'll just keep that as on the list. I'll be honest with you, I probably shouldn't since it's probably being recorded, but if I were treating some woman who was pregnant cervical strain, I wouldn't be bothered at all. I might be a little less inclined if I were doing the low back or something like that, but I'd rather doubt that her epicondylitis at the elbow or it would be an issue. But it is a contraindication, and so we would. We always use the contraindication of sensitivity to electrical fields. I don't know exactly that I've ever had a patient that had a problem with that, but nonetheless, keep that in mind. Yes?
One of the questions that has come up in the field, Steve, on the pregnancy thing, the therapist, when they use gloves, and they use 2 gloves, is there any problem with the therapist? I mean, should the therapist who's pregnant be doing the treatment?
Yeah, it's a good question because unique to this treatment, and Rob, everyone was able to hear that question, you assume?
Yeah.
Okay, let me repeat it just in case. I don't know how good our sound is here. Larry asked the question of what about the therapist who happens to be pregnant and is delivering the treatment? You mentioned 1 glove. I don't know, 1 glove, 2 gloves. That's irrelevant as far as I'm concerned, but it is a good point. Because there's an electrical field set up in the operator as well as in the receiver or the patient. And so if we are going to say that we're not going to treat pregnant patients, it's probably a good idea to avoid using the device if the therapist or physician is pregnant.
What about the probe versus the glove for the therapist?
Now, okay, we can obviously use the probe, not using a manual type of thing, and in that case I don't believe that the therapist would be in any particular risk because there's no electrical field that's established in the operator in that case.
No different than delivering an ultrasound treatment.
No different as far as I'm concerned. Because we don't have any, this is tested for stray electricity and that sort of thing. So that unless you and or your patient are part of the field, have been connected into the field, then there shouldn't be any risk at all. Okay? Other questions about the contraindications. Always important to discuss the contraindications. We don't want to hurt anybody, which is not an issue here, really. Okay, very good. So, now, let's, Scott, before I launch to the next thing I want to do, is anybody already firing any particular questions?
Yes.
All right, let's hear those and we'll deal with them.
Any good ones?
This first question comes from Gil Courtney. So, he says, can we demo this on PTs like we do with light on, say, neck strains and expect to get the phenomenal results that we get with light?
Yeah. Well, I started by giving you probably the best example answer to Gil, right, Gil?
Mm-hmm.
Gil's question that I can think of. My cynical partner with 7-8 year standing extensor epicondylitis was treated one time with unbelievable relief of his pain and increased motion. So yeah, absolutely I would expect that. Now I will tell you that if I were in the dealer's position if I could go to a clinic and treat a total knee that was maybe 3 to 4 days post-operative, then I would probably pay someone to let me do that. Because the pain relief that patient will experience, the increased motion they'll experience, and just visually looking or circumferentially measuring the amount of edema that will be reduced by a 10 to 15 minute treatment is remarkable. And I love total knee patients since I've started to use the deep tissue oscillation, because they just do so well. So well, in fact, and I hate to say this, but it's the truth. We have total knee patients who are driving 50 miles or more to come to our clinic to be treated with this, because the word's out how much pain reduction that they get. So yeah, you can expect that, Gil. It is that dramatic, but I find that that's probably the most dramatic. Now, if you're in a sport environment, sport rehab environment, probably if you can get to the women's volleyball team with all the ankle sprains that they have, that would be another good one. You know, if you can combine both pain and edema, if you can find both pain and acute to subacute edema to treat, that's just like hitting a home run. Just, you know, muscle strain, the pain associated with that, sure, it's very effective. Very effective. But if you can get really a bad case, you know, real swollen and hurting, and then treat it, that's where you'll see the biggest results immediately, quickly. Okay?
One more question. Rodney Rice is asking how deep this treatment goes. How deep is the effect?
Yeah, it's a very good question, and to be extremely specific, you know, I've not set up a laboratory experiment where I can say 2.68 centimeters or whatever, but I can tell you this, that we are treating the muscle tissue in the low back, which, as you know, is the erector spinae group is 4 layers thick and several centimeters, you know, in thickness, and we get a tremendous reduction in muscle tone there. So I would assume, or you should assume, that the treatment, the depth of the treatment is equal to probably ultrasound, which we usually figure is up to 4 to 5 centimeters. So I don't have documentation to prove that, but nonetheless, it seems to be clinically that that's the case. Depth is not an issue. Depth is an issue with ionophoresis. Depth is an issue with some treatments, with light and with deep tissue oscillation, soft tissue oscillation. It's not an issue. It's not an issue. Shouldn't be a problem. Now, it's also important to note, Scott, and who asked this question? Rodney. Rodney, it's important to note that increasing the pressure of application beyond simply a good contact, good, you know, nice contact, is not necessary to increase the depth of the treatment. In other words, the resonant vibration that's set up from the treatment is there. Increasing pressure does not increase that vibration, the strength of it, or anything of the sort. Now, you may have reason to increase the pressure of the application of what you're doing for a mechanical purpose, but that has nothing to do with the resonant vibration that's set up with the soft tissue oscillation. Okay? Does that make sense? Did you follow what I mean? The vibration is there if you make contact. The depth is not increased by pressing harder. You may have reason to press harder for something you're trying to achieve, but it has nothing to do with that vibration. Okay? Any other questions?
Yes. Have you used this on lymphedema patients? And if so, how do you address the cancer as a contraindication in this situation?
Okay. So, very good question. Someone's actually paying attention to me in the morning, and I'm now 50 years old, and so people have started to not pay attention to me, so I appreciate that. It basically means that someone's thinking. So who asked this question?
This is Richard Singletary.
Richard, you're an intelligent scholar, and we appreciate you being part of this today. It makes sense. First of all, lymphedema does not have to be associated with cancer. Okay, let's get that on the table. If a woman has a mastectomy and much of the lymph drainage in the axillary area is removed and radiation is used, frequently lymphedema is a result of that because the lymph channels are damaged or scarred or whatever. At least that was the case frequently in the past. It's less so now because the techniques are better. But lymphedema can occur whether or not cancer is part of the patient's problem at all. In fact, it can be a primary diagnosis. So treating lymphedema with this treatment, I have done once, because I don't really treat those kind of patients, I just happened to have one time, is a very good thing to do. And it's good for a couple of reasons. Number one, if you're familiar with lymphedema treatment, current practice, the Vater technique is probably the most commonly used technique now. A massage on the proximal part of the body and then moving distal to proximal is the treatment of choice. And pressure is to be light and the frequency should be low, about 20, 25 pulses per second. So this is a perfect treatment for that. Now, back to the question, to the important part of the question. If the patient has lymphedema as a result of a metastatic disease, then that would be a red flag, and we would need to investigate the deal. Let's say that the person's been treated, and their oncologist feels that they are, that their tumor has been removed. Then I think the treatment, you'd have to do it in concert with the treating oncologist or surgeon or whatever. But that's easy enough to do. You just sit down and talk about, Also, there are a number of patients who may be terminal even with their cancer, and to give them some relief and some improved quality of life and function even though they are terminal. Many times we do this with electrotherapy to control their pain even though it is a contraindication, but we all sit down with the patient, with their physicians, and we say, okay, this is what we can offer, but these are the risks, and then those risks are evaluated, and treatment sometimes is done anyway with the patient's blessing. So, yeah, it's possible to treat that patient. Is that good? I want to cover the whole area of that question because that's a pretty good sized question. It's not. Okay, anything else?
They're coming in pretty good.
Okay, well, do you want to do more of those? Or you want to see some example of treatment?
Maybe pick some of the ones you think are
all right.
relevant, then we'll move to treatment.
There's more questions about mechanism of action.
Okay. Well,
I would say anything that's going to be covered by the stuff you're going to talk about.
Okay, well, let me do
the stuff that you've already talked about. If they've got questions, let's go back. And
let me do another mechanism of action, just a little, to try to do a real clean, quick example. Okay. We had a picture a while ago. Let's go back to that picture. I hope this doesn't, like if your computer's slow and I just blew it up, I apologize. This one here's so nice and fast. Okay, this picture, if you can see this now on your screen, you kind of refer to it. The mechanism is really a push-pull effect. All tissue, all matter has a charge associated with it. And whenever that matter and its associated charge is introduced near or in an electrical field, those charges respond to that electrical field. In this case, the electrical field that's established in the operator and in the patient are constantly alternating. And as they do, the charges associated with the matter in the patient's body that we're treating is either drawn to the charge in the operator or repelled from the charge in the operator, and this basically just causes the tissue to be pushed and pulled or vibrated. The result of that on the soft tissue is something that probably could be categorized, and I'm just kind of making this term up as I go, but it could be categorized as maybe a micro massage, like a massage at the cellular level. Or, for that matter, if you had this might work. If I were to put some dirt in this bottle of water and it had precipitated to the bottom, okay, aggregated at the bottom, and then I came and gave it a little vibration, then it would be distributed in the liquid, right? Well, we have soft tissue and lots of liquid in our body, so basically that's what we're doing to that tissue, is just vibrating it, breaking adhesions, breaking the aggregation at the bottom of that bottle, making it more pliable, making it softer, that sort of thing. That's one part of the effect. The second part is that excitable tissue, i.e. nerve tissue and skeletal muscle, are stimulated by the soft tissue oscillation, by these electrical fields pushing and pulling, just like they are with electrical stim. The nerve is depolarized because of the stimulus of those electrical fields. And when it is depolarized, then we get a pain reduction by the same production of neurotransmitter substance and enkephalin, endorphin, just like we do with electrotherapy, depending on the frequency that we choose. High frequency with the soft tissue oscillation from an electrical and neural point of view is no different than high frequency TENS. Same effect in terms of the neurological system and pain control system. And then the third point mechanism is the mechanical application of either the probe or the operator's hand mechanically moves fluid, stretches tissue, whatever, depending on the technique that you use. The three together are what we're calling soft tissue oscillation therapy. Was that good? Those of you who listened, is that helpful? Okay. All right. Let's do some examples. Tell me your name again.
Oh, Matt.
Matt is our patient. Matt, come around onto the table. And let's get Matt. Matt doesn't even have a pillow. Matt, will you lie back onto your back? I'll give you a little bit of a bump on your head there. Is that good? Can you live with that, Matt?
That's great.
Okay. Are you still able to see Matt's? Let's go with Matt's knee first. Okay? We wouldn't happen to have like a towel or something around here, would we, in case I want to clean Matt's leg off sometime? Let's say that Matt has just had a total knee replacement. That's what we're going to do first. Okay? And Matt, I'm going to ask you to hold this in your hand. This ground mass that Matt was going to put Matt's side of the frequency into the deal. And then I'm going to use first this smaller probe to treat Matt. And I'm going to be honest with you because Larry said it was okay for me to be honest. I don't use the probe on that much. I use my hands. Let me have it. There you go. But we're going to do it first with the probe, and then I'm going to do it with my hands. Yeah, just rest your knee there. A lot of people, one of the things that we need to do here with this treatment is keep the field dry. In the past, you're doing electrotherapy, you always want to be sure the patient's real hydrated and the skin's not too dry because the current doesn't flow as well. You need to remember that we're not causing current to flow here. In fact, we're putting an interface where current doesn't flow. And so we use powder as a medium so that we can keep the area dry, and we can move the probe very readily. Now, one of the things that people do, I see done a great deal, is they tend to use too much powder. It's not necessary to use so much powder that you begin to sneeze and the whole room turns white and that sort of thing. That's not necessary. Another thing to remember is if you put too much powder on, it tends to start to cake up, and then you don't get the two, thank you sir, the two electrical fields sufficiently close together. You add a layer of distance between them. So just enough so that you keep the area dry and you can move your device, whether it's your hand or the probe, is what you're after. Okay, back to the situation. We have a total knee replacement. So picture Matt with an incision, something like this, and he's got a lot of swelling around his knee. Most of the time, the swelling will be greater medially than it is laterally. We never say forever, but what I would do is I would work the area where the greatest amount of swelling is, and usually what I'll do is I'll work above the side of the edema for a few minutes, 2 or 3 minutes of the treatment, and then we'll return and start to move from distal, away from the heart, toward the heart, and pretty much in longitudinal patterns. Now, I'm not putting a great deal of pressure on Matt's tissue, just enough to maintain good contact. And as I'm doing it, and you notice the speed's not all that great either, because what I'm actually thinking about as I'm doing this, without putting so much pressure that it hurts, I'm thinking about sort of moving a fluid wave ahead of me. So I want to give time to do that.
What frequency are you using, Dr. Guthrie?
Right now I'm using about 100 hertz.
100 hertz.
Yeah. And again, up to 200, but anything 80 and above in the acute situation seems to be effective. And I have not found that, you know, I'll be honest with you, I've not found that 200 is better than 120. You know, now in this case when they're real acute, I have found that 80 to 100 or 120 is better than 25, okay? But I've not found that, you know, there's a huge difference on the upper end. All right? Now, everybody getting the idea here? Pretty simple treatment, actually. Now, it helps, obviously, if the operator knows something about how does the joint capsule lay here, what tissues are underneath what I'm doing. Like, for example, here I'm just kind of following the medial collateral ligament. But I know that the joint capsule comes and attaches right where I am here. And so from about this point to this point is all joint capsule. So I will make sure that I cover the whole area with the treatment. Okay? All right, now,
Because elevating the limb.
yeah, at least to heart level, you know. And this is another reason why I frequently will use a little bit of a roll behind the knee, because if the joint is bent just a little, that gives maximum space in the joint capsule. If it's flexed excessively or fully extended, there's less space in the joint capsule. So this allows for the fluid to move a little bit better. Okay? All right, now, let's just be true. Larry, please don't throw anything, okay? Let's be true and do this the way I do it. All right? And that is, I'm going to use my hand, because I think that you will find that you're going to want to do it this way. And it's very effective. Okay, I'm placing a barrier between myself and the patient by using a latex glove or rubber glove. I've connected the patient in the circuit and myself in the circuit. Doesn't matter where you put these, by the way. Makes no difference, really. Just kind of out of the way. And then I'm just going to put the slightest little bit of powder on my glove. Then I'm going to set up my frequency, you know, the way that I want it, as we were discussing a moment ago. And then the reason I like to use the gloved hand so much is I can feel now where the fluid is accumulated, and I'm going to work and milk, basically, that fluid forward. Now, I'm thinking in my mind, as I'm doing this, about trying to relieve tension on the muscle, trying to move fluid. But what I actually know is going on in the background is that I have this high-frequency TENS, if you will, taking place that's helping relax the patient, helping with pain control after I've been doing this for 4 or 5 minutes. And then as I move the fluid, that relieves a lot of the discomfort the patient's feeling. I can also at the same time mobilize his patella, which is a problem when you have edema because it'll start to stick. Now, what you'll notice, and this is completely, you know, to be expected, if I stop moving my hand, then you will not feel any vibration any longer. But the moment that I begin to move my hand again, the vibration will return. That's completely normal. You have to keep moving so that you have a charge difference going on all the time, alternating, to be able to keep the field in place. Okay? Are you with me? Now, I proceed on a treatment like this with a fairly acute total knee for probably a minimum of 10 or 12 minutes up to maybe 15 minutes. I've done some up to 20 minutes, but I'm not finding that the difference between 15 and 20 minutes is appreciable. You know, and time is important to me, so about 12 to 15 minutes is probably a typical treatment that we'll do here. All right? Now, let me give you one other little tip. You don't want to touch with your other hand unless it has a glove on it, because it kind of lights the patient up. And you don't, it's not going to kill them, but it, you know, like that. And you, sometimes what I find is, and you kind of got to watch this, I might be over him, you know, doing something, and then my arm touch him on the other leg, and that'll light him up a little bit. So you kind of got to be careful about that. If you, there's nothing, you could use a glove on the other hand and use both hands if you wanted to. And sometimes we do that on like flat surfaces like the low back or whatever. Okay, all right, so fairly light touch, distal to proximal, in this acute case, distal to proximal. Probably a good idea to spend 2 or 3 minutes initially kind of working the upper leg, in this case, to sort of open the lymph channels a little bit, and then come and do the rest of your treatment below. Part needs to be about at heart level, elevated a little bit. You could elevate it even a little bit more. If we have a joint, we want to put that joint in what we'd call the loose pack position, so that the capsule's not excessively stretched, which would interfere with the fluid moving away. We are using a high frequency. Okay? 10, 12, 15 minute treatment. Follow it then immediately with some good range of motion type exercises, whether they be, you know, active assistive or even passive, and then maybe move to more active stuff. What I really like here is we'll get these people now on a cycle, and now they can turn revolutions on the cycle real readily, where when they walked in the door, there's no way they weren't going to do it at all. You know, they had too much pain, too much swelling, and that's what and that's a really good way to evaluate the effectiveness of the treatment there. As you can see the patient walking, you can see what they're doing, and then you do the treatment, and then you kind of put them in the same environment again, and you can truly quickly see the difference that it's made.
If you're going to couple this with light therapy, do you do light pre or post?
Yeah, if I were doing the light, I would probably do the light first and then do the treatment.
Just to kind of open it up?
Well, no, because I don't want the powder all over their leg while I'm doing the light.
Okay.
I don't want to get it on the lens of my... There's not any reason why it would matter, you know, other than I don't want to get the light probe, have powder all over the lens and interfere with the transmission of light.
Okay.
But they work well together, and I very frequently, Quinn will do it just that way. You know, I would probably do, you know, tibial tuberosity, around the tibial tuberosity, around the plateau, and then on either side, femoral condyles, you know, just kind of, and usually I'll come popliteal space in the back and do 3 to 6 joules, you know, at each one of these places, and then do the deep os. That's a very good combination. Follow that then with the exercise, work them really good, get finished, might even do E-stim and ice when it get done. Okay? Other questions about that? Yes, sir.
A question to Matt himself. How did that feel to you as a patient?
I thought it felt really good. I definitely enjoyed it more when he did it just with his hand. You could get, he kind of got the entire area of the knee. It just felt a lot better. But the way it felt, I really liked it.
Am I really messing up, Larry? But okay. The beauty of using the hand instead of the probe. If you've got a nice flat area, the probe is great. But so much of the treatment that we do here is joint related. You know, it's an irregular surface. It's geometric. You know, rather than just a flat plane. And being able to use your hand to feel, to tell where things are tender, where tone is higher, where fluid is accumulated, all those sorts of issues that are being processed, you know, by the therapist at the time they're doing it. It's just, there's no comparison. The effectiveness of it is greatly enhanced whenever you do that. So I recommend it highly. I do. Okay? Now, any questions then? So we did an acute situation that had edema and a lot of pain, and we just happened to use the example of a total knee replacement. But it could have been an acute sprain, you know, playing football or something like that. It was non-operative. Same method. All right? All right, Scott, we got anything on that topic we need to deal with?
There's a lot of operator questions
All
right now. Some, can you use two hands?
Yes, you can use two hands. You'd have to glove both hands.
Why don't you demonstrate that
Yeah.
quickly? so they can visualize what you're talking about.
Dr. Duffy, when you use both hands, would you want to take your watch off on the one side? Is that going to give them a bigger shock than just if your skin touches them, or is it the same thing?
I'm not going to touch them with anything, but it's a good Quint. In case you didn't hear, he said, what about my watch? And I wouldn't want my watch to touch them. And so if I were worried about that, I would take it off.
Right.
Now I have my ring on, my wedding ring on inside my glove, but the glove insulates it, so that's not a problem. But yeah, you make a real good point, and so I'm with you on that deal. Everybody. But I promise, Matt, I won't touch you with my watch. Okay. All right. This device, and Larry and Scott, correct me if I'm wrong, but it has a real good ability I've found to do defaults the way that you want them. And so I set mine up where I just have to make 1 or 2 key punches, and I do the things that I do all the time. Okay, so now we have 2 gloved hands, so no problem. Now, it does diffuse the oscillation a little bit.
Because it spreads it over twice the area, right?
Yeah, it does, and so you may not notice quite as big a displacement in the vibration. And one other thing you need to know is that since the surface area of that electrode that attaches mass is what, 2 square inches, something like that? Well, 4 square inches. It's a 2 by 2, isn't it? It's not quite a 2 by 2. It makes no difference. It's small, all right? When I put a lot of my hand on the patient, I'm using a lot more surface area than that. So, Matt, when I do that, do you feel more underneath that electrode that's stuck on your leg? Can you feel much under there?
No.
Okay, well, good. A lot of people will feel it. And if they're holding a ground mass, I have found that if you start using your entire hand, the patient may start to get some sensation in their hand if they're holding the ground mass, or under the electrode if that's the case. And so just be aware of that. It's not going to hurt anybody. It's not any big deal. But the smaller surface area becomes more active because there's greater density of current, that reaches that point. So just, be aware of that.
Well, if you're dispersing the current over 2 hands, are they getting somewhat less of a treatment or less oscillation than you are with one hand, and therefore it's a disadvantage?
I think that Matt can kind of help us with this. I have clothes on, Matt, so when I bump your foot, it won't hurt. Now, if I did with just my bare belly, it would, so I'll keep my shirt on. You notice what you feel here, right? Okay, now, if I incorporate both hands, how big a change is that?
It's not a big change.
Yeah, it's not a huge change. I mean, it's some change, but the benefit you get from being able to use 2 hands to do something, if that's your desire, is probably much greater than any loss you have in the depth of the vibration or whatever. Depth is the wrong word, the intensity of the vibration. Okay, that help? Works just like a charm to use 2 gloves. Super duty. Okay, what else?
Can you talk a little bit about the placement of the electrodes? They need to be close to the field,
Okay.
Size of electrodes.
Let me have a little voodoo room there. I simply place them somewhere out of the field that I'm treating that's flat and adheres well. And with the guys, and I looked on Matt, and there's just not any way to do it on Matt. Someplace where there's not a whole lot of hair. For 2 reasons. One, the hair lifts the electrode a little bit, and sometimes that can cause a decrease in conductivity. And then when I take it off in a minute, we're friendlier, Mr. Fennell, one of my professors, said, always do the thing that feels the best last. And that gets them to come back the next day, We do this, which feels the best first a lot. But when I pull that thing off, if I pull his hair, that's the last thing I do with this treatment, So I really want to be kind of careful. So I try to put it somewhere where there's not a whole lot of hair. Now, beyond that, I probably wouldn't put it up here on his chest. I don't do electrode placements pre-quarterly, I don't want to, not that I fear too much, there's not a lot of power here that I'm going to, change the rhythm of his heart, but I just don't do that, all right? And I don't think I need to get like miles away, but out of the field that I'm treating, and then on me, just somewhere where it's not bothering me. And since I tend to do a lot of this one-handed, I do some too, but I do a lot of it with one hand. I always put the electrode on the other hand so that I'm not sweeping this cord around all the time, you know. So I just put it on my other arm, you know. There's not any, Scott, to finalize that answer, there's not like this huge, important, measure so many centimeters, turn left, and, you know, breathe twice and then apply the electrode. It's not that important as long as it's just out of the field. Okay? All right. Now, just to show you that it doesn't make any difference, you know, you asked a while ago, does it make any difference where you put the electrodes? I'm not even going to change sides of his leg. I'm not even going to put it on this leg, just leave it where it was. We're treating a new leg now. But we're going to attach the electrode to him on the other side. Boy, you need a little, tighten that muscle tone up right there. Okay. All right. Now, bend this knee. Just bend it up. Let's say that Matt here is a 70-year-old male, and he has really bad OA, osteoarthritis in his knee, and he's really a candidate for a total knee, but he doesn't want to do it because he's wanting to wait until late in the fall when it's cold and he can't play golf. See? So he's putting this off. So they send him to me, and here's what he says. He says that the medial side of his knee, bend the other knee so they can look at this, says that right here he hurts all the time. Now the reason for that is because the tibial plateau is worn down, the hyaline cartilage on it is worn down, and so he's kind of bone to bone, you know, and he's just getting a lot of bone pain right here. And boy, this will just be so sore, you can even press on it and it'll be very, very sore. Okay? No swelling, because OA is not an inflammatory disease, it's a degenerative disease. And so what we're going to do this time is we're going to use about 50 pulses per second. So a little bit lower frequency. And what that's going to do is that's going to give us a pretty good displacement of tissue. Okay? And we'll just go ahead, and that way everybody on the camera can see what we're doing. And we're just going to come, and whereas before, when we had edema, we were worried about clearing the lymph channels above and all that sort of thing. All we're going to do here is just apply this right over that tibial plateau on the medial side. And just simply, I usually kind of use a circular pattern, and I'll feel around and kind of watch the patient. And if I'm finding a place that's real tender, like, you know, you've got some gracilis sartorius attachment here, hamstring attachment below. Sometimes those areas will be a little irritated. And I'll just feel around for them and find if there's an irritated location and just sit here and work on it. And pretty soon then, my friend Matt will be quite happy because this will relieve a lot of his pain. And then we'll usually do this 10 minutes. And then what will happen is we'll take the light pad and we'll set it up over the medial side of his knee. And we'll do 1 or 2 cycles through with the light pad. And then, of course, we do a lot of strengthening with the quadriceps and the hamstrings and that sort of thing to stabilize the knee so that he doesn't put as much pressure on his knee. But this is not an acute situation, see, like we were doing a while ago. He walked in, he's going to walk out, he just hurts. And especially when he pivots on his golf swing, you know, it hurts and that sort of thing. And he just has osteoarthritis in his knee. So we went from one end of the spectrum, which was a very acute operative case, to the other end of the spectrum, which is a very chronic non-operative end of the case, deal. Simply change the frequency from a high frequency where we're mostly dealing with acute pain to a lower to moderate frequency where we're dealing more with subacute to chronic pain. I might even sometimes do this at 25 pulses per second. Just kind of depend on how he responds. If I don't like the first response, I'll probably lower the frequency in the chronic deals rather than raise it. Does that make sense to everybody? Because chronic pain we use a lower frequency, acute pain we use a higher frequency. Very simple. And I often will treat this patient in this position right here so that I can get to the tibial plateau real well. I can feel the joint line, so I can kind of go over the edge of the joint line and deliver the treatment that way. I can feel all the tissues that attach to the tibia. and I can feel the femoral condyle, the end of it here, and so I can kind of see if there's any areas that are tender there. Just simply treat them. The deal. It's a point-on type of a treatment in this case. Does that make sense? Okay, good. That's a good one, isn't it? Yeah. Now, while I got him here, I've had a number of patients this year that have torn their gastroc, that work in factories, and there's this one place that apparently there's a whole bunch of climbing up and down steps with heavy boxes. And I've gotten 2 or 3 people that have just kind of stripped the gastroc doing that. And in this case, they'll come in swollen, even have ecchymosis, be discolored and the whole 9 yards. And so we'll start with the acute deal like we were doing with the knee a while ago, high frequency. We'll do the hamstring real good, and then we'll come and do distal to proximal with light pressure. And then after a week or 2, as a lot of the swelling and the discoloration resolves, then we'll go down to the lower frequency. And in that case, I'll start really working the muscle manually to break up adhesions around the area of the tear so it doesn't scar and shorten. And when we finish the treatment, we'll do stretching, with the patient. Very good. Speeds the healing rate. Most of these people are, walking without a crutch in 2 or 3 weeks, and typically they'll be on crutches for 6 or 8 weeks, So it works, speeds up the rate quite a bit. That's another one where I would use the probe light, because I could find in the gastroc tear, I can palpate and find exactly where the tear is, and then I would apply the light right to that very spot. The lower end. It's not complicated. It's pretty much repetitious, to be quite honest with you. It's a very simple type of a treatment. Let's look at the rotator cuff thing briefly. Go ahead. Okay, rotator cuff. When a person has, we'll say preoperative rotator cuff syndrome, typically they have pain here, which is the attachment of the supraspinatus tendon, which began here, goes underneath the acromion process, attaches. They may have some bicep, long head of the bicep involvement, which is very similar location. Now turn and stand so we can come behind. They frequently will have discomfort in the infraspinatus here. They may have some in the mid-belly of the supraspinatus, and then if the capsule has tightened, they'll have pain right where the deltoid inserts. And so what we'll do a lot is lay them on their side, so lay on your side facing these guys, so that shoulder will be up. You can kick that little round pill out of your way. You're making me dizzy circling there. Okay, just lay on your side. There you go. And so in this position, now just rest your arm. In this position, see, I can work all of those from distal to proximal. It gives me an opportunity, like I can use my thumb, to work any area where I feel tightness or problems, especially on the supraspinatus attachment. I can even include the upper trap. So this is a real good position for treating. I work around the shoulder blade if you've got anything that's adhered around the shoulder blade. And for those of you who get ticked off that are watching, I would put the electrode probably here or maybe on his back that connected him, or have him hold the ground mass when I did that to be complete. I'm tired of putting that glove on and off. I think everybody's seen the glove. Right? Okay? Question? Okay, now if I were, let me see how I put myself up here because I've changed everything. If I were doing, hold this in your hand, Matt, just make contact with the silver part. If I were doing a low back, let's just do a mid back. We're going to say that Matt has showed up in the clinic here, and Matt is one of those ultimate fighters. Okay? And Matt, we're going to do a test there. Matt's an ultimate fighter, and he got beat up pretty good last night. But the big thing that happened to him, let me change sides of the table so I don't interfere with the view of what's going on here. And he got kicked. They do a lot of that kicking, I noticed. That's not really, that's what, when I was a kid and you kicked, we said you fight like a girl. Now you make a lot of money doing it. Anyway, he got kicked real good right in his mid-back, and he has a, hematoma here, and, of course, a lot of associated muscle spasming, and it's real tender. So first of all, how much pressure am I using here?
Very little.
Just enough to make contact, because he may still be kind of actively bleeding a little bit, So what I'm mostly interested in doing is relaxing the muscle around the area and just kind of eliminating the pain. So what frequency am I using?
High.
So give me a number.
1 to 120.
Okay, I've got it set just that very way, Quinn. And I'm just going to kind of work the area, and I probably am going to work the area that's peripheral to it too. Like around the edges of it, below and above it. And it almost looks like you're doing ultrasound, doesn't it? It kind of looks that way. And that's the way I would probably do this. Now, when he gets less acute and tender, I would probably go with my hands then and really work that mechanically. Here's just good for making contact. Okay? But when I really want to do something more mechanical, I tend to use my hands. Now, what I would probably do then, I finish and I probably clean this off, and then I put the light pad on. And I might even cover that with a cold pack, or do you see? Just what you probably already. In my opinion, this treatment has so much greater circulatory effect than either the light or ultrasound that they shouldn't even be compared to one another. I mean, I'm serious. It's that dramatic. It is extremely dramatic, this circulatory effect, compared to those other two. Okay? It is the thing to do if you're trying to increase circulation.